Welcome to a new episode of Evidence Echo.
Today we're plunging into something really critical, but often overlooked, I think. It's the elimination of hepatitis B and C across Africa. Our mission really is to understand the huge burden, unpack some surprising barriers maybe, and spotlight the innovative solutions and the success stories that are paving the way forward. You might actually be surprised by the scale of the problem, but also by the potential for a healthier future that feels like it's within reach. Okay, so let's unpack this a bit. Hepatitis in Africa, it's a massive public health crisis, right? But it's often silent. We're talking millions affected, and so many don't even know they have the virus until it's tragically late.
It's a staggering burden, absolutely. For hepatitis B alone, estimates are around 82 million people chronically infected just in the WHO Africa region. It's actually the leading cause of liver disease there. Think about this. Nearly 1 million new infections every year and 80,000 deaths. Annually. Yeah. To put that in perspective, Africa carries about 28% of the world's entire chronic hepatitis B load. And then there's hepatitis C. Globally, maybe 58 million chronically infected, but African nations, they see some of the highest rates. Sometimes, up to 26% prevalence in certain areas.
26%?
Yes. So combined, Hep B and C affect over 91 million people in Africa. That's about a quarter of the global burden right there. And the consequences, well, they ripple outwards. Liver cirrhosis in sub-Saharan Africa. The death rate is almost double the global level. And Hep B is the main driver.
Double.
Yeah. And liver cancer, hepatocellular carcinoma, was the second leading cause of cancer deaths in men, third in women in WHO Africa back in 2020. What's really alarming, too, is co-infections, like HIV and Hep B, or Hep D and Hep B. These can dramatically speed up how quickly people get to those severe liver conditions. It makes a bad situation much, much worse.
So it accelerates the damage.
Exactly. And far too often, people only get diagnosed when they already have late-stage complications.
Okay, but here's where it gets really interesting, maybe frustrating, too. We have these powerful tools, like really effective vaccines. They've been around for decades. So why? Why are we still seeing such high rates of new infections, especially with hepatitis B?
That really is the core paradox, isn't it?
Yeah.
Hepatitis B is entirely vaccine preventable. The WHO has set this target, it's ambitious, reducing Hep B in kids under 5 to less than 0.1% prevalence by 2030. Globally.
Okay.
And the key strategy, particularly in Africa, is the hepatitis B birth dose vaccine, the BDV, giving this shot within 24 hours of birth. It's incredibly affordable, it's cost-effective, and it can stop 90% of mother-to-child transmission.
90%?
Yeah. I mean, look at China. They were once an HBV epicenter now. They're on track for an HBV-free generation, largely thanks to this birth dose strategy. But the implementation in the WHO Africa region, it's lagging significantly. Only about, 30% of countries even have policies for universal BDV?
Only 30%.
And fewer than 10% of African infants actually get it on time, within that 24-hour window. In 2022, coverage in Africa was, frankly, dismal, 18%. Compare that to 80% in places like the Western Pacific.
Huge difference.
Yeah.
So why? Why the gap?
Well, the sources point to a few things. A historical lack of dedicated financial support, even from major players like Gavi, though they've recommitted recently after COVID delays. Then there are the practical challenges, right? Maintaining the cold chain for vaccines in remote areas. That's tough.
Yeah.
And the high number of home births. It just makes reaching newborns in that critical first day incredibly difficult. And there's more to it. A recent big analysis, a meta-analysis on how well the vaccine actually works in African kids, found something worrying. The overall level of seroprotection, that's the antibody level you need for protection, was only around 57%.
Lower than you'd expect.
Right. Now, some places like South Africa did better, maybe 87%, but others, Ethiopia, for instance, were as low as 52%. So this sort of suboptimal effectiveness tells us that even when the vaccine is given, we need really consistent, robust strategies to make sure it's fully protective. Beyond the birth dose, there is another tool. Antiviral therapy for pregnant women who have a very high level of the virus, high HBV DNA.
Okay.
Starting treatment around 28 weeks of pregnancy can further cut the transmission risk, but less than 1% of pregnant women in Africa are screened and treated for this.
Less than 1%.
Yeah, mostly because access to the viral load tests needed to identify who needs treatment is just extremely limited, and it creates this stark disparity, Women who have both HIV and HBV often get tenofovir as part of their HIV care, and that drug also protects against HBV transmission, life-saving.
Right. It does double duty.
Exactly. But women who only have HBV, the mono-infected women, they often don't get access to the same treatment.
So it depends on their HIV status.
Often, yes. It shows how we could leverage existing systems, but we often don't for hepatitis alone.
That brings us to people already living with hepatitis B. And the numbers there sound just as, well, sobering. It feels like millions who could benefit from treatment are just being missed entirely.
Yeah.
What's blocking the way?
You've hit the absolute critical point there. We have effective, affordable antiviral treatments, yet less than 2% of people living with Hep B in Africa are even diagnosed.
2%.
And only a tiny fraction, 0.1%, are actually getting treatment. This is what we call the treatment gap. And it's not a gap, it's a chasm, affecting millions who are at serious risk of progressing to liver failure or cancer. The barriers, they're multi-layered. For one, the treatment guidelines we use, they were mostly developed for high-income countries. So they're really hard to implement in resource-limited settings. They often require lots of repeated clinic visits, lab tests. Just not feasible for many.
Right, the infrastructure isn't there.
Exactly. And there's a glaring lack of affordable diagnostics. Basic things like molecular tests for HBV DNA to see how active the virus is, or specialized tools to assess liver scarring like FibroScan. They're prohibitively expensive, they're scarce. Fundamentally, the entire HBV care program in Africa is just severely under-resourced. And here's another striking point. Awareness, or lack thereof. It's a huge hurdle. There's this widespread misunderstanding that HBV is mostly caught in childhood, not sexually transmitted. And that, unfortunately, feeds into significant stigma. Plus, because it's often this silent disease, only showing up with severe complications later in adulthood, healthcare tends to react to crises rather than preventing them.
Reactive, not proactive.
Precisely.
But okay, despite all these really significant challenges, I understand there are some genuinely innovative strategies emerging. New ideas that could maybe fundamentally shift how we tackle this treatment gap. Tell us about those.
Exactly. There's real momentum here. Experts are pushing for dramatically expanded and simplified treatment criteria, moving towards what some call a treat-all-accept approach.
Treat-all-accept. What does that mean?
So instead of spending precious resources trying to pinpoint only the absolute highest risk patients using complex tests, the idea is to identify the few who are at very low risk and then treat almost everyone else.
Flip the script.
Basically, yes. This would dramatically increase the number of people getting life-saving therapy, and alongside that, proposing decentralized, community-based treatment programs. Adapted for rural, low-resource areas, it means bringing care to the people instead of making them navigate complex, often distant health facilities. Imagine linking HEV screening to things already happening in the community, like census drives, village festivals, maybe even working with religious leaders during major celebrations. It's about meeting people where they are.
Makes sense.
And Egypt provides such a powerful example here, even though it was for hepatitis C. Their national screening campaign managed to reach pretty much the entire population in a remarkably short time.
Incredible.
Yeah. These kinds of community-based proactive approaches are absolutely crucial for finding cases early and connecting people to the care they desperately need.
That's a perfect segue. Because Egypt, this is where we really see a powerful success story, right? Offering lessons for the whole continent. Their journey with hepatitis C sounds, well, revolutionary.
It absolutely is. Revolutionary is a good word. Egypt historically had the highest burden of hepatitis C in the entire world. Over 6 million cases, largely due to unsafe injection practices during mass treatment campaigns for another disease, schistosomiasis, decades ago.
Well, a legacy issue.
A terrible legacy. But they made this bold decision. We're going to tackle it head on. So in 2014, they launched 100 million Seha, which means 100 million healthy lives. It was this huge national drive aiming to eradicate hepatitis C by 2023.
So ambitious.
Extremely. And the core of it, offering free testing and treatment to everybody. And the key was the widespread use of direct-acting antivirals, the DAAs. These drugs cure over 95% of hepatitis C cases. They gave them to everyone diagnosed.
Just free access to a cure.
Essentially, yes. And success was built on several smart pillars: creative financing, social solidarity funds, health insurance working together, plus, crucially, locally produced generic versions of the DAAs and shrewd price negotiations.
We're getting the cost down.
Massively. They also significantly improved blood safety, infection control, harm reduction practices, vital supporting actions, and huge public awareness campaigns. You couldn't miss it. Plus, they built a really robust surveillance system to track their progress meticulously. The results, they really do speak for themselves. By 2022, over 60 million people had been screened, over 4 million treated.
Wow.
New infections plummeted. from 300 per 100,000 people back in 2014 down to just 9. Overall prevalence dropped from a staggering 10% to just 0.38%.
Unbelievable turnaround.
It really is. Egypt is now the first country to hit the WHO's gold tier status on the path to Hep C elimination. It's a genuine blueprint.
So, okay, connecting this back to the bigger picture, Egypt's success isn't just about Hep C, is it? It really feels like a powerful model for other African nations trying to achieve similar goals for both Hep B and C elimination. What's the key lesson here for the rest of the continent?
I think the core lesson is the power of integration. And leveraging what already exists, Egypt's success provides that blueprint, absolutely. And one of the most promising paths forward is integrating Hep B and C care into existing successful health programs, especially HIV programs.
Tap into that infrastructure.
Exactly. The WHO's Triple Elimination Initiative targeting HIV, syphilis, and Hep B mother-to-child transmission is a prime example of that synergy. The Global Fund, for instance, now lets countries request resources specifically for viral hepatitis. It's about not reinventing the wheel when effective mechanisms are already running. Integration also means simplifying guidelines, like we talked about, and embracing task sharing, shifting some responsibilities from specialist doctors to nurses to other health officers.
Decentralizing care.
Yes, and decentralizing care away from just big hospitals. These were winning strategies in the fight against HIV. We don't need to learn those lessons all over again. Now, addressing the money challenge is paramount. Generic tenofovir, the key drug for Hep B, is low cost now, but access for people who only have Hep B is often restricted.
Because it's tied to HIV funding.
Largely, yes. It's mainly distributed through externally funded HIV programs, so we need concerted action. Policymakers, industry, international donors, they need to step up to ensure broader dedicated funding specifically for hepatitis. And another vital lesson from Egypt and elsewhere, the power of advocacy and community involvement. Civil society groups are already doing incredible work on the ground, like Women in Hepatitis Africa. They've trained over 5,000 African women as hepatitis champions.
Wow, hepatitis champions.
Yes. And it leads to real impact. Like in the Makoko community in Nigeria, they saw over 90% birth dose vaccine uptake driven by these low literacy women advocates.
That's amazing.
It shows patient voices, community voices are crucial for driving change, for tackling stigma. When communities are empowered, things happen. Which brings up this question, why is understanding the whole system so critical here? Implementing something like the Hep B birth dose with that strict 24-hour time limit, it introduces huge logistical complexity.
Right, it's not just having the vaccine.
Not at all. You have to think about how it interacts with, well, everything. Service delivery, cultural norms, political will, transport, cold chain. Addressing these really tangled health system complexities is vital if we actually want to scale up delivery and see real impact continent-wide. Ultimately, look, achieving elimination requires a coordinated call to action. It's got to be everyone pulling together. Policymakers need to ensure birth dose access, make HBV DMA testing universally available, develop those simplified African guidelines, prioritize active screening, maybe embrace that treat-all-accept idea.
Okay.
Industry has to ensure affordable access to drugs and critically reliable point-of-care diagnostics, tests you can use right there in the community.
Makes sense.
And academia, researchers, they need to prioritize sharing data from Africa, doing high-impact research focused on the region, natural history, risk factors, cost-effectiveness of different care models. It really is a team effort. But the blueprint, thanks in part to places like Egypt, is there.
Really. The status quo for hepatitis in Africa, it's just intolerable, isn't it? This silent epidemic causing so much suffering. But the path to elimination is challenging, yes, but it feels absolutely achievable. We have the vaccines, we have the treatments, we have proven strategies like Egypt's 100 million seha showing us what's possible. It's clear that concerted effort, integrated solutions, really understanding local context, and frankly, urgent action are the keys to unlocking a hepatitis-free future for millions across the continent. So maybe the final thought for you listening is this. Considering the remarkable success of Egypt with Hep C and everything we now know about Hep B, what role can individuals, what role can local communities play in demanding and supporting these critical health transformations in their own regions? Something to think about. Thank you for joining us.